More than 60 million people in the U.S. sniffle and cough every year as they deal with allergies. That is according to the CDC. The reason behind all the robust pollen right now and why some allergies may prevent you from getting COVID-19. More on that coming up now on the Morning Medical Update. And good Monday morning to you. It is July 11th. I'm Jessica Lovell. We are here inside the Dolph C. Simons Jr. Family Broadcast Studio. Thank you so much for joining us this morning on Facebook, YouTube, and Twitter. TV star and host Carson Daly was in recent headlines about a new procedure he had done that our pain specialist has been doing for 2 years. We'll have more on that story. Dr. Dana Hawkinson will join us with the latest on our COVID-19 count, plus the latest headlines involving the virus. And a new report by the Asthma and Allergy Foundation says allergies are among the country's most common but overlooked diseases. Dr. Bill Barkman is here. He is a pulmonologist and critical care medicine physician here at the health system and an expert in environmental and building air quality. He's the man. Good morning to you. How are you?
Good morning.
Good to have you, as always. So we'll get to that here in just a moment. And as always, this update would be nothing without you, our viewers, and your great questions. And as we have seen over the last 2 years, you've got a lot of them. So please get those sent in to us on YouTube, Facebook, Twitter, and you can email us at the Medical News Network. You can find links to all of those right there on your screen. 32 million Americans are living with back pain right now. That's according to the Chronic Back Pain Organization. And one of those people was NBC host Carson Daly, who recently underwent a procedure. Joining us now to talk about that is Dr. Dawood Sayed, Division Chief, Pain Medicine, and Vice Chair of the board at the American Society of Pain and Neuroscience. A big title. So we're glad you're with us today to talk all about this. So Dr. Sayed, you've been performing this procedure here at the health system for the last 2 years. So tell us, what is it called? What does it entail?
Yeah, thanks for having me on, Jessica. So what Carson Daly had was a procedure called the intercept procedure. Technically, it's called basovertebral nerve ablation. It's a lot of words to say, but it comes from about 30 years of research. For a long time, people with been called having an entity called degenerative disc disease. And a lot of the treatments, procedures, and surgeries for targeting the degenerative disc have had failure rates of as high as 50%. So this is kind of a new and innovative way of targeting these types of patients with chronic low back pain from that, where we target actually not the disc itself, but actually the interface between the disc and the vertebrae. It's a disease entity called vertebrogenic pain, and a lot of people are suffering from this. Really we find it on MRI. We can find these degenerative changes in the vertebrae on any type of MRI, even on a CAT scan. And if patients have back pain that they've kind of had for more than 6 months that has failed conservative measures, they could be potentially a candidate for this new procedure.
Well, and this is when celebrity news can be helpful, because when somebody like Carson Daly has some type of ailment or then get some type of procedure, it becomes a headline, and then people get to learn more about it and find out they're not the only ones. You actually know the doctor who did Carson's procedure. How do you know that guy?
Actually, it's her. It's Dr. Karen Patel. Yeah, she's a fantastic physician. We trained together back in New York City over 10 years ago, and we've done a lot of research together and worked together on a lot of these new and novel therapies. So she's a wonderful physician, really one of the leading physicians, not just only in New York City, but around the country. And having a high-profile patient like Carson Daly, who's from what I saw from the story and talking to Dr. Patel, he's just been a really good advocate for patients suffering from chronic pain. One thing with this procedure, as with a lot of new procedures, access and coverage through insurance can be a struggle. So Mr. Daly has been a really big advocate for his struggle. It took him almost 4 months to get his insurance to authorize this. He was eventually able to get it authorized, and he's doing wonderful from the story that I saw. So I think there are some challenges when we talk about these newer therapies, but having celebrities with a big mic that can get some of the word out really do help, because a lot of people are just suffering unnecessarily. Think about something like chronic low back pain. Either we suffer from it ourselves, or we definitely know someone that does. And a lot of these new treatments are out there, so there's answers for that.
A couple quick questions. We know Carson was a good candidate. Who else would make a good candidate for this procedure? If somebody's at home and they're having pain, they've been living with pain. How do they know that maybe they might want to reach out and find out more information about this?
Yeah, so there's a couple things that could potentially make you a candidate for this. One of them is, you have to have back pain. We typically want patients, we think are good candidates for this, is most of their pain is localized to the low back. Not a lot of pain shooting down into their legs, things like sciatica or radiculopathy. This is really more for patients that have pain that's localized kind of to that belt line in the lower part of the back. The other thing is, typically patients should have had an MRI. And on that MRI, what we like to see if candidates are candidates for this are degenerative changes in the spine. So, and specifically what we look for is something called modic changes, M-O-D-I-C. It's some sort of a word that people probably look on their MRI and they see it and they have no idea what it means. But what it means is that there's been a long-standing degenerative process in someone's lumbar disc that's actually starting to affect the vertebrae. And that's why we target the nerve that goes right into that vertebrae. It's a new way of kind of targeting the pain signals. We've done things into the disc, into the joints. We fuse the discs together. And again, as I mentioned previously, failure rates can be as high as 50%. With this therapy, now we have almost 10 years of data for it. We were involved in the clinical trial almost 5 or 6 years ago. And we see that, patients at 5 years out, 85% of them would say if they had the chance to do the procedure again, they would. On top of that, the safety profile of it is very good. We have in the published literature and with, the experience with over the last 2 years, 0.3% complication rate. Any complication that does happen has been very limited and mild. So very safe procedure as well.
And that's good to hear, because I would imagine going down the road of trying to decide if you're going to have back surgery would be very concerning. So that is good to hear. But I do have to find out what is the recovery time for something like this, maybe compared to another type of procedure.
Yeah, so I think if people have had things like lumbar injections, it's very similar to that. It's a little bit more, it's not as, involved as having back surgery. It's probably somewhere in the middle. So it's an outpatient procedure, typically done through a 1 inch or a ½ inch incision. We access that vertebral level. The procedure takes, about 30 minutes, and patients go home the next day. Recovery is usually, some soreness from the procedure itself. There's really no limitations as far as, activity. People are fully walking and ambulatory that night. Usually people notice some sort of response or improvement in their symptoms at around 5 to 7 days. Peak results usually around a month. And then usually what we've seen so far is the results are sustained. A lot of these injection or ablation type procedures we've done in the past, one of the big downfalls is them, they do really well for a short period of time and then the pain comes back. We've kind of followed these patients out to 5 years and really there hasn't been any change in the pain relief. So we think this is most likely a permanent procedure.
All right, lastly, if folks are in pain, how do they find you? How do they find out more information?
Yeah, I think there's a lot of good resources on the internet. I think if you go to our health system's website and put in the word spine, you can find myself and you can find our spine center physicians. There's myself performing the procedure and, a couple others. So I think, there's a lot of resources out there. I think also for patients, if you want to get on to just find some information generally about this procedure called basivertebral nerve ablation or the intercept procedure, how it's branded, you can go to relievant.com, RELIVIANT, or you could just Google the intercept procedure and you'll find it. It's pretty easy.
Always great to have you on. Thank you so much.
Thanks, Jessica.
You bet. Okay, allergies affect more than 20% of Americans and in fact is the 6th most chronic condition out there. Common symptoms include everything from sneezing to runny nose, itchy eyes, coughing, even rashes. And it's caused by everything from pollen to pet dander, food, and medication. Joining us now to talk about this and this growing allergy problem is Dr. Bill Barkman. He is a pulmonologist and critical care medicine physician here at the health system. How are you?
Good morning,
Good
Jessica.
How are you? Did you have a good weekend?
I did, and you?
Good. We're always
Great.
glad to have you in here with us. So it seems like we always say at this time of year, it just seems like the pollen's really bad and the allergies are really bad, Dr. Barkman. Is that true, or does it just feel true?
No, I think it is true as people pay more attention. And again, this time of year also with the heat and all, we start to see the ozone effect so there's the environment also plays a role in stirring up symptoms and especially the cough, sneezing associated with asthma. So I think, there's a lot of concern about change in climate. We've got longer growing seasons. There's more pollen. We don't really have a good background of what the actual numbers are, but clearly people feel that they're having more symptoms earlier and more persistent. So there's no question that it's a real deal. And again, one of these things that most people treat their allergies over the counter. They don't necessarily even see a physician. And so we don't really actually know the true number. And but the ones with severe disease need to see an allergist and get plugged in, because there's new treatments out there, and especially for the asthma type conditions associated with allergy.
So we know it's bad now. Now I'm asking you to get out your crystal ball. What's the fall going to look like? What are your thoughts? When we see it look this way now, what does it tell us about a few months from now?
Well, I think, and toward August, end of August, we're going to see ragweed come out, and so you're going to have another peak of it there. So again, the spring we see grasses and trees. We've gone through that. But then we get to the fall, we're going to get the ragweed, and it'll pick back up, and so we're going to have another peak sometime in August.
Does it seem to get worse year after year? Because that's what people with allergies always feel. Gosh, it's really, really bad this year. Or does it just vary back and forth year to year, just based on climate and weather and all the factors that go into allergies?
It varies. It varies. And you can't necessarily predict coming into the season how it's going to be.
So what are the best ways to treat allergies? You talk about over-the-counter medication. I have to tell you, my daughter suffers allergies, so I went and had her back pricked and all the things came out. And yes, she was allergic to all the things that I thought she'd be allergic to. But really, when it came down to it, there's not a whole lot to do other than over-the-counter medication and try to environmentally keep yourself protected from some of those things. What do you suggest?
Well, and I think you've hit on the key part. First of all, if you develop allergies, you have to have a diary of what's bothering you. And so avoidance, like you say, is the key.
Yeah.
But of course, you can't avoid life. And so some of these things you're going to have to figure out. Antihistamines you can buy over the counter. And some of the new, like I say, IV asthma medications or injection medications are helpful there. But if you really can't handle the avoidance and just over the counter, then you may go to a specialist who actually gives you immunotherapy with shots. Essentially what you're trying to do is the body's trying to develop a tolerance so it doesn't give you the same symptoms and you don't get really sick from it.
Any reason why somebody couldn't just be a lifelong over-the-counter medication taker? And does that cause any long-term issues? If you just have allergies and you just do your Claritins and all those over-the-counter medications, is that okay? Is that enough?
If it can be,
Okay.
Yes, it can be. It depends on what bothers you, and it's nice if you can take a break in those medications sometime during the year to go along with the cyclic. But there's really no, adverse effects for those long term. However, we know that sometimes one doesn't seem to work as well, so then you flip to another one. Maybe you go from Claritin, Allegra to Zyrtec, whatever, and there are always new ones coming out.
Right.
But yeah, there's really no long-term effect of those.
Of doing that. Okay, so that could be a treatment if it works for you. Let's talk about drug allergies. How does that impact patient care if somebody has a drug allergy?
Well, again, it's one of the key questions we ask people when they come in the hospital. Do you have allergies to drugs, say penicillin, for instance? And it's an important issue because, again, usually in a hospital setting, you're the ticket to get in, you're fairly ill. And if you have a significant reaction to this, that can lead to a serious outcome in the hospital, organ failure and prolonged hospitalization and all sorts of things. So again, drug interactions can also occur with that. So it is really an important issue. The drugs, we know what the interactions are.
It seems like a good question to ask when somebody comes here to the hospital, but how in the world would you know? I've been asked that. My answer is usually always no, because I've never had any issues, but you don't have an issue until you have one.
Correct. Well, and that can happen. It can be a rare occurrence, but generally speaking, a lot of folks have had interactions before. And it's in their outpatient. Either, they've had minor symptoms, nausea, vomiting, feeling bad. Maybe they had a rash.
Right.
In terms of penicillin is usually a common drug. And so, again, if they've been given it as an outpatient and they develop a rash, any of the antibiotics, that's the case.
Sounds like it's important then to know your body, document that, make sure you're communicating all the details, even small ones, to your physician.
Exactly. You need to keep a diary of those things so that down the line, and same with the food allergies, what foods bother you and what is the symptom. And because if you go see a specialist, they're going to want to know the most they can so they know how to test you. Do they do the shots or the pick in the back? Do they put on patches? Do they draw blood samples? It varies depending on what they think it is. And so the more you know about your body and what compounds bother it, the better off you are in terms of directing your medical care.
So you mentioned food allergies, people who are allergic to peanuts, milk, shellfish. Tell us about those. How rare are they? How common are they? What can you tell us?
Well, they're not rare. Are they super common? No. Shellfish, probably in adults, there's quite a few people that have that, and they seem to know it after they've had one episode with it, because they get really short of breath, and some of them have to carry EpiPens because of the potential of an arrest from it. In the kids, there's a lot on peanuts, as you're well aware, and they're starting now. I'm not a pediatrician, but they're starting to work through introducing peanuts so that the kids can develop tolerance to it, and so maybe they won't be life-threatening because you get on a plane and is it cross-contamination? Everybody's concerned about that. Do you have allergies for peanuts? I mean, you go to a restaurant and they ask you that,
right? Because
cross-contamination can happen. And so I think those are common. Everybody knows those. I mean, allergies to milk or inconsistent, it's a lactose. That's really not an allergy in a sense. But again, people are aware of that, and they can have milk without the lactose in it or take the tablets to give the effect of it. Again, I think nuts and shellfish are very common. People are aware of that. And again, once they've had that reaction, they're going to avoid that. But again, sometimes you get some food, you don't realize what's in it.
Yeah.
And then you have to be prepared, especially if you have a life-threatening kind of reaction to it.
Well, and it must be nice now that restaurants, when they walk up to your table, one of the first questions, what can I get you to drink? And do you have any food allergies? Because we don't want to have an episode right here at this table, right?
Exactly. That's excellent.
All right, let's turn to Dr. Hawkinson. We're going to bring you in on this conversation because there was a recent study that found that it was harder for kids with food allergies to catch COVID. What would that mean? Can you help us explain that?
Yeah, I don't think we have a good answer for that. I think that was a surprising result found in a larger study. So they weren't asking that question specifically. Again, this was in a pre-vaccine period of time. Early in the pandemic, the viral circulation probably was not anywhere near where it is now. If you look at the time frame from that study that it was done, they don't offer too many discussion points on why that is. Number one, there could be differences in the of just going out and being in those exposed places. They also do offer some molecular information. Maybe there's just a lot of inflammation going on because of those allergies, and with that inflammation, you have some active inflammatory process already going on to help reduce that. Overall, though, I don't know if that data would stand up if that question is specifically asked, especially now with the current amount of high prevalence of the virus around our nation, really, and in our communities.
I have a couple of COVID headlines I want to get to, but let's get to our numbers first.
Yeah, so we have 26 active infections in the hospital. And of those, 3 in the ICU, 2 on the ventilator, 11 in that recovery period. So our numbers were down a little bit, I think, to 21 or a little bit lower, but kind of popped back up. Unfortunately, we know that the cases continue to be very high. The running 7-day average tends to be around about 100,000 per day if you're looking at the Washington Post. And again, those are just the confirmed cases that are reported. Those don't include the home testing or people who aren't testing. So there's still high viral circulation, but luckily we aren't seeing necessarily the high amounts of hospitalization. But obviously you can see that the hospitalizations still are higher than they had been a few months ago.
All right, the latest CDC map says that those living in Leavenworth and Wyandotte counties should mask up again. We know that's not the case everywhere in the metro, but what do you think of this?
Yeah, I mean, I think we know the virus is circulating there. I think understand those risks of what you're going to be doing. Are you going into a restaurant or a bar, any other enclosed space where there's a lot of people? I think it's smart to wear your mask, especially if you are one of those people that are at higher risk of hospitalization and severe disease. I don't believe there will be any further mandates or restrictions just because of other issues not related to public health or medicine, but other issues that go into those types of decision making. So it's really incumbent upon you as an individual or your family to understand those risks. And if you feel like you're going to be in some of those higher risk situations, certainly wear a mask.
All right, is it COVID or allergies? We know people have asked that question since COVID hit. So Omicron now, those symptoms can make it even harder to tell. So how do we tell the difference and know if it's allergies or not?
Yeah, I think you have to understand, have you had allergies in the past? But we know people can develop allergies. We know that with SARS-CoV-2, a lot of those symptoms are going to be those upper respiratory or head type symptoms. It's going to be very difficult to tell. I think you should always test, and we know that people who don't even have any seemingly high-risk situations are still getting SARS-CoV-2 or still getting COVID. So it's important to really get that testing done.
All right, let's move to monkeypox. So the first presumptive case in Kansas is said to be in a Johnson County man. What do we know about that?
Yeah, I don't think we know much other than what was in the press release, and I think there was a recent travel with that. I believe they are not hospitalized. And again, for most people with monkeypox, you are not going to have to be hospitalized. Certainly, we know some of those symptoms can be quite severe. We know that there are treatment plans in place. You have to work with the KDHE and the local health department, and that is being done. But we also know the Health and Human Services is rolling out a vaccination plan for those people that may be at risk of acquiring this. So still more information to come, but right now, again, most people are not going to have to go to the hospital. This patient is not hospitalized, I don't believe, and is just being managed as an outpatient.
All right, hang tight. We are going to get back to you in just a moment, but I do want to get to a viewer question for our guest, Dr. Bill Barkman. Jill wants to know, how effective, Dr. Barkman, are air purifiers? Which ones do you get? Do you have to have the big expensive ones?
Well, that's a good question, and it's debated some. And by themselves, they're not a total strategy. But for instance, if you were at work and you're in one place and you're worried about the environment there, and usually we don't do much sampling because that's a little tricky, especially if you're sensitive to something. Levels may be lower than would be safe, but on the other hand, it bothers you. The other place is at home, and potentially you spend, 8 hours a day in a bedroom. Mm-hmm. So having an isolated one there can be of help. Usually the HEPA filter ones are the best. I mean, some of these will remove pollen and particles from the air. And the ones that are ozone based and trying to clean air, that's kind of a mixed bag. So in terms of filters, if you're in a position that for instance, at night you're going to be there, put it on, or at work if you're going to be in one room. But again, you've got to do the other strategies too. Mm-hmm. I mean, again, if you're outside doing work and you're going to go to bed, you want to be sure and shower, get the pollen off of you. From that standpoint, have your house allergy protected, get rid of the rugs, etc. Avoid compounds that bother you. So it's part of a strategy, mm-hmm. but don't put all of your hopes in one machine. Yeah. Getting you where you want to be with your symptoms.
Yeah, you're asking a lot of that
right.
that purifier. And how important is it that we? I know your answer already, but how important is it that we replace air filters just in our home?
Well,
I say every 3 months. Is that?
Yeah. Well, again, and you should. And some people, even those are electrostatic in some furnaces. So, but yes, you should replace those routinely. And people that are really allergic, some of them in older homes should have their ducts probably cleaned also, because they over time can collect dust and particles, etc. So. Not so much in the newer homes, but the older ones. But certainly I would, the filters should be replaced on a routine basis. And during, it's not probably a common recommendation, but during high seasons for pollen, like in the spring for the grasses and trees, when you go outside and your car's covered in the green pollen, those, and then in the fall, you probably need to really put them in and at those points, so that because those could be the highest risk.
You make a good point. It's like you have to make a good checklist of all the things that need to happen to give you the best outcome, not just one thing.
Well, and during the winter, of course, it's dust mites are going to be more common, and of course, that's a different strategy than the outside. So again, people with allergies typically read and get up to date on these sorts of things. But it's important, again, back to the diary, knowing when it's going to, and if you know your symptoms are going to start the 1st of March generally, then you can, some of your medicines you start a couple of weeks before, so that you don't wait till you start getting symptoms.
Yeah.
You start. And the issue of separating allergies from COVID, those symptoms, again, the one that we're seeing in clinic that is really at this point is severe sore throats. And you're not going to see those with allergies. I mean, postnasal drip, yes, but you don't see the severe sore throats. If you've got a severe sore throat with the sniffles and all, like Hawk says, you need to be tested.
Never hurts to be tested. I love this talk about the diary. I bet you there are people listening and watching right now that might start that medical diary. It seems obvious, but it seems like a lot of answers lie within that.
Right, about your own body.
Yeah.
And of course, I'm old school, so I have a calendar on the wall and I have a place to write.
I love it.
And that's, where everybody does it in their phone nowadays. But again, I think, the more you know about your body and the years and the cycles, the better off you are to adjust your treatment. Because everybody would be, I think, of the agreement, you don't want to be on medicine if you don't need to be.
All right, so if you're just joining us, we're talking, of course, with Dr. Bill Barkman. He's a pulmonologist and a critical care medicine physician here at the health system, but he is also an environmental and building air quality expert. So, Dr. Barkman, some researchers believe that the inflammatory substances that cause allergic reactions in the body may also affect the brain as well, playing a role in the development of depression and anxiety. Can you explain that?
Well, I don't think we have all the answers there for that. I mean, but I do think that I think there is concern about that, and that is not related just to adults. That can be kids also, because severe allergies that give you symptoms again affect your lifestyle, and it affects your mood. And so it can be depressing, I mean, you got headaches and the sniffles and your cough, sneezing, everybody's looking at you like, do you have COVID? And I think the actual mechanism is probably not quite clear. The inflammation that you see with allergies is typically IgE, which is a little different process than you would see with a virus or whatever. So where we just talk about general inflammation. Because if you develop allergies to something, what's happening is your body's producing a protein against it, and so when it sees that, it reacts. And if you get severe symptoms, it's an overreaction. Yeah. Whereas if you have a bronchitis or a sinusitis, it's an infection. That's an inflammatory process that's against a bacteria or a virus. And so the biology is a touch bit different. And again, I mean, what do you say? The body has to have a process against inflammation, pro and anti, so it's a balance. And again, I think the important part of it is trying to understand, okay, is this an allergy and it's going to go this way and I need this medication, versus is it an inflammatory process? In terms of the brain and how that plays, not sure I understand that, but on the other hand, clearly it's a mood downer, and so it would affect people with depression and anxiety. And so, yes, I would expect allergies that give people chronic headaches, that is going to affect their mood. And again, we need to address the holistic side of that.
All right, we talked with Dr. Hawkinson earlier about food allergies and COVID. So a recent study finds that all people with certain allergies are 50% less likely to get COVID. I'm going to let you both jump in here on this one, but why would that be?
Yeah, I mean, again, I think that we don't fully know that. These studies weren't really directed at determining that question specifically. Some of those results were just found during the study. That wasn't a question that was specifically asked. It was an interesting anecdotal data for that. Certainly I think we need to ask that specific question moving forward and really looking at that. I think, again, things are different now. Is it just an overall amount of inflammation that's present because of those allergies? That could help reduce that. Is it other practices, just general practices that maybe help reduce your chance of exposure as well? And I don't know what Dr. Barkman would say as well.
Yeah, I don't think we know. I mean, I think it's an interesting observation,
Yeah.
but the questions weren't asked the right way to help us understand the biology.
So talk about the link between allergies and tinnitus. Kind of explain what that is or what that might be.
Well, the ringing in the ear sort of situation, I'm sure. Again, that's felt to probably be related to inflammation of the eustachian tube that connects your middle ear to the inner ear to your throat. People who, in an airplane and you notice the change in altitude and you feel the pressure there, well, that's related to the eustachian tube needing to open up to equalize things. So, yes, I would expect allergies to do that, just like people with sinus issues. It causes that inflammation. And again, generally that gets better fairly quickly if you treat the allergy. The thing you got to be careful with this is it's going to usually be on both sides. If you only have it on one side, then you really need to be evaluated by a hearing specialist or whatever to determine if there's more to the story. Somebody needs to look in your ear and see, is there anything there? If not, maybe you need to see an otologist, because unilateral usually it could be something more serious. If it's bilateral, it's associated with your allergy. You treat that with a decongestant that typically defervesces it, and you're okay.
Yeah, you don't seem too surprised that some of these things are not all tied together.
Right. In fact, I mean, nasal polyps and sinusitis, very common with allergy. And so this would all tie together very nicely. It's just part of the upper respiratory system, which is really set up to help clean the air before it ever gets to the lung, so it doesn't cause other issues. Remember, below the vocal cord, the lung is considered to be sterile. And so that's why all this upper screening stuff goes on to purify the air so that what gets to the lung doesn't cause as much of an issue. And of course, even your bronchial tubes produce phlegm to help clear this stuff out. Again, so it doesn't get down into the alveoli and cause inflammation. Again, you can have allergic kind of pneumonias. You can have chemical kinds of pneumonias, so they're not all bacterial from that standpoint. So the system's set up to help protect us, and when that inflammation picks up, it gives us symptoms in terms of sneezing and headaches and that sort of postnasal drip.
Okay, I've got a weird one for you.
Okay.
All right, what is a water allergy? Have you heard of this? How would you treat it? What is it?
I wish I knew the answer to that. Obviously, common sense would tell you, because the body's 70% water, that's can this happen? Well, it's got to be something that's attached to the water molecule, either an allergen, could be a toxin. And again, if you're concerned about that, you really do need to see a specialist. They probably would do some testing by putting some water on you in a form that they can evaluate whether it's causing an actual reaction or not. To my knowledge, I didn't know anything really about this. It's obviously very rare.
Yeah.
And the workup, again, would be a little, tricky perhaps. But again, back to what was in the water. I mean, again, that potentially could have caused the issue. And again, most of this is probably going to be local and not life-threatening. But, again, I don't think we know enough about it. And it's so rare, I don't think there are lots of studies going on to be evaluated. I'm sure you could even ask some of the allergists, well, how you work that up? And they're going to look at you like, but it's going to be one of those topical things they're going to put on you, look at it, see where you go from there. So rare as heck, but I would say it's the water molecule being attached to something, either a toxin, or some sort of pollen.
Okay, so here's an item I always have in my house, Dr. Barkman, which is honey. I always have honey sitting out on my counter, and it's local honey, and we've always heard that that's good to help with allergies. Is that true?
Well, the theory being that if you're from this area and you've lived here for a significant period of time, because allergies take time, you have to be exposed, then the body has to develop a system to it. So it's not, you don't walk into a room and get allergic to something like pollen the same day.
Okay.
It's going to take probably at a minimum a month and probably longer. So, but if you've lived here and you've developed allergies here, and you've all heard the story back in the day where, oh, well, you got allergies here, you should move to Denver or Arizona or whatever. And so what happens, you're down there, eventually you get allergies to the compounds there. I mean, you're allergy free for a while, but then the body is going to catch up to whatever the compounds are there. Well, in terms of the local honey theory, again, the bees are going to bring part of the pollen back to the nest where they're making the honey. Now, generally, my understanding is, and I'm not a botanist, but flowers, obviously, the pollen for that is a little different. It's stickier, and so it's not out there like ragweed.
Right.
But having said that, if the bees are bringing it back and putting it in the honey, what you're doing by eating honey then is you're really developing a tolerance for the compound, similar to what you would start out with an allergist that's giving you shots to desensitize you. So you'd start out at low doses. So in theory, and some people swear by this, what happens over time is you require less allergy medicine because of this exposure, and you're developing a tolerance. So, I mean, there's no harm to having a honey, and it may in your particular case help, but I don't know of a test to say, oh yes, you should do honey.
So just like the air filter, don't rely on local honey to fix your allergies. It's just going to be one more thing to put on the checklist that might help.
But yes, and it's healthy. Honey's healthy, so why not?
All right, do we have any reporter questions on the line today? Because I want to get to some community ones. And a comment from Georgianne. She said she loves Dr. Barkman, by the way. Says that you truly understand allergies and asthma just like she has. So, Georgianne, if you have any questions, please send them in. But you're a little bit of a relief for her today. So, but I've got a few for Dr. Hawkinson. Yeah. Some COVID questions for you. And I wish Dr. Sayed was here, but you might be able to help Yen Liang. She's asking how low back pain might be included in the symptoms of long COVID. Any connection there with that?
Yeah, I mean, I think you can just have an exacerbation of any active problems that are going on, such as pain. We know long COVID, it's very difficult to identify. We know the slightest things can be considered with long COVID, such as just fatigue, which can occur after any illness as well. And so I certainly think that with that, you can have an exacerbation of those existing issues, such as chronic low back pain. I think that's certainly reasonable. Hopefully over time, that would go back more to what it was at its chronic nominal level, but also is that just a progression of the pain as well, and of that process going on.
Jo Ellen wants to know, with the newest COVID variety, she's been just checking out some articles that say it's easier to catch COVID outside. She said this is very disheartening. Can you address that, the outside factor?
Yeah, I mean, I think if you're close with people, I think most people would still continue to be consistent with the same information that we've been saying. Outside is definitely better. Obviously, if you can be separated from people, typically the wind currents are so turbulent that doesn't allow for much exposure to that. I've seen some of those articles as well. Again, some published studies, but there are caveats to those things also. So I don't think much has changed from that, and I certainly don't believe that any of the information or the guidance has changed as far as outdoors is definitely going to be much safer, much less exposure than compared to those indoor situations.
Couple of questions about Paxlovid from
Yeah.
Michelle and Katie. She said, could you please speak about Paxlovid and rebound? I feel like this really needs to be discussed.
Yeah.
I know people who have taken it, felt better, tested negative, then rebounded with worse symptoms
Yeah.
and started testing positive again.
Yeah.
Katie asking, is there any change in protocol for people who have taken Paxlovid?
Yeah, there actually is not than what they have now put out. So I think that in the trials for Paxlovid, they saw about a 2% rebound rate. That also is said to be consistent with people who have actually had COVID and felt better and then felt worse. There was a large study published that showed it was like 0.8%. But I think the other numbers I've been hearing out there is like 2 to 5% of people taking Paxlovid will have that rebound. So if you do experience that rebound, you should re-isolate for those 5 days and wear that mask for that 10 days. Just as you normally should. We know that Dr. Fauci took a second round of Paxlovid, and we were quite surprised by that because still in the FDA and the CDC recommendations, there's no evidence to support that you need that second round. I think we would certainly all be for clinical trials looking at either a longer course of Paxlovid or taking a second round, but right now the guidance would still be just taking that one first round of Paxlovid. And then what they have seen is that people that do have rebound, they do not have more severe disease. They are not at any more risk of going to the hospital or going to the ICU. So it's just important to get back into that re-isolation process for those 5 days and then wearing that mask then for that total of 10 days.
All right, help Nancy out with this one. She says her daughter has still not had her period for 7 months after taking the Pfizer shot.
Yeah.
She says she seems to be the only one concerned about this, so not sure if she's talked to her doctors or not. But she said, have you heard of any information on things like that happening?
You know, I thought we had actually more questions about people having abnormal bleeding after vaccine. So I think that is a question probably better directed to our OB-GYN colleagues. They would have more information, Dr. Al, Dr. Weinecke, and just ask your OB-GYN as well.
All right. I figured you wouldn't have lots to add, but I had to ask. So Maria, though, has a question. Dr. Barkman, what if you take Allegra and Flonase year-round? Is that safe? That's the question I had earlier, so let's go over that again. Is it safe to just treat with over-the-counter all the time?
Yes. But again, if possible, I would cut your dose back in part of the time. In other words, you could do Flonase twice a day, but maybe you can get by with once a day depending on your symptoms. Maybe you can take it at night or in the morning, depends on when your symptoms are worse. So I would again try and decrease, if possible, some. In terms of long-term side, we don't know of any because they're both safe drugs. I mean, they're all over the counter now. And so, again, I don't know of any long-term. You can take them for long periods of time. Sometimes you have to rotate them.
Right.
Even though the molecule's essentially the same, it may not have the effect. And for instance, and how do we decide that? It's just common sense. Geez, I don't think my Claritin's working. Well, let me try a different one.
Right.
And see.
Switch it up.
But safety-wise, the safety profile's there, or we wouldn't be able to buy those over the counter.
Well, and I like the idea of taking a break. My daughter's 9 and has really bad allergies. I feel horrible, and I give her kids Claritin. But I've noticed if she doesn't, she'll need it. But then when she doesn't need it, we don't take it. So then she'll go, she could go a week or so without needing it. And then all of a sudden it'll flare up again. So then we start taking it. So kind of ebbs and flows.
Right. And that's good. And then if it's spring or fall or winter is your worst time, then you can stop it for some of the periods that don't bother you. And then, start it up a couple of weeks before. Don't wait till you have symptoms. For instance, if it's spring, start it in February and before everything comes out. And then hopefully you won't have the symptoms that affect your lifestyle because as we talked about, mood switches, headaches, those sorts of things, it affects people's productivity.
Last question from Angela, and I find it interesting because I've often wondered it. So peanut allergies, when I grew up as a kid, I'm sure when Dr. Hawkinson was in school and when you were in school, I didn't hear of peanut allergies. Or were they there and we didn't know that that's what it was? Or do allergies just come into the world in our lives and there's some reason why now a peanut is now something that kids cannot tolerate and like you said, maybe it'll go away And maybe something else will come into play.
Well, new allergies do develop. I mean, just like we have new things, chemicals, new other things in the system, allergies do develop at all ages. I mean, I've seen people in their 80s that had the onset of allergies.
Okay.
They said, well, I can't have it because I'm 80. Well, no, you can. And they do. In terms of kids, you know, I think, and I'm not a pediatrician, so I don't want to get too far out here, but back in the day, I mean, we got peanut butter all the time.
Yeah.
And then they went to say, well, maybe you shouldn't give it to kids under a certain age. I don't know that they've changed the processing of peanut butter or whatever, but the severe reaction people's had, if we would have had that back in the 50s and 60s, it would have been known.
Sure.
So something changed.
Okay.
And we don't know if it was a change in the way, the age that we started giving them exposure to peanuts.
Right.
In terms of peanut butter, it wouldn't be peanuts per se, they'd be too young to eat them. Or was it a process issue? We don't know.
So interesting.
It is,
But-
but now they're finally getting their arms around trying to develop tolerance to it so it isn't life-threatening, because everybody hears about the case that, you know, they can't breathe, et cetera. Not the mild cases, but the severe cases. And that's frightening for anybody, let alone a child.
But I think it's tough. I just like what people didn't believe about COVID. You know, you have an allergy that is now in kids that wasn't when a parent was back in the day. So then people go, well, that's not even a real thing. Is a peanut allergy a real thing? And so it's nice and I'm sure very comforting to parents who have kids with these severe allergies to hear it is a thing.
It is a thing. And in fact, tree nuts can cause a different kind of an allergy too. We don't, you know, I mean, obviously peanuts are grown underground, but tree nuts also you can have allergies too. So again, they fit in that list of concerns. And so again, common sense would tell you to pay attention to those things. But I think in terms of the peanut, if there are concerns about that, you should talk to a specialist, an allergist about that.
Well, a tricky little specialty you've got going on because there's so many factors. I could talk to you all day. So we're going to wrap up. So I want to get your final thoughts. What do you want folks to know here as we kind of get towards wrapping up summer and going into fall? What should people know?
Well, I think, again, we're going to get into it's already been warm in Kansas City, but it's usually August is a little hotter. And humidity, and again, we get these high centers that come and sit in here, and our ozone levels go up. That's going to affect COPD and asthma. And so one has to plan their day around, you know, if you're going to do things, you want to do it in the morning. Because again, what the sunlight does is convert the nitrogen dioxide and all from internal combustion to the ozone. So that's why everybody, you put your gas in the morning, you don't do it in the late afternoon. You just do all these things to cut your exposures down, and you don't get out in the heat and run and do those things that time of day. So, and then if you have health problems associated with allergy or asthma associated with heat and humidity, you have to work around it and set your day based on the environment. And we're going to get into another allergy peak here, well, within a month. And so be prepared. And you know, I think if you have those allergies, people do tend to prepare and get ready so it doesn't affect their lifestyle as much. But, you know, again, if you're just developing, and I've had some people that claim, you know, they didn't have allergies before COVID and now they have allergies. Well, in some respects, that biologically makes sense. I mean, if your airway is torn up with a virus, and now it allows other kinds of proteins in, could you develop sensitivity? Yes. Has that been studied? No. But, you know, again, it's one of those things we've seen before that people that have viral bronchitis and then later develop more allergies, I don't think there's any question that happens, but there's no science. We can't expose people and then try again, you know, that wouldn't pass human subjects. But we also see it in people have been exposed to chemicals that had a bronchitis. In other words, their airways affected. This allows proteins to get in contact, and then the body sees that protein as negative, and so it'll develop antibodies, and there's where your allergy comes from. And so, again, it's one of those things that be aware. You can develop allergies at any age. And Again, if they get severe enough that you have hives, if you have hives or shortness of breath, you need to see a specialist. I mean, yeah, rashes, headaches, postnasal drip, yeah, you could treat those over the counter. Hives, shortness of breath, you need to see a specialist.
I knew right before I was going to let you go, somebody would ask a question. So I'm going to ask you this. This will be your a couple of questions real quick. Kathy wants to know, she feels constant pressure in her ears. Is that caused by allergies? She's been to an ENT. That wasn't super helpful. So what do you think that is? Go to an allergist?
Well, I guess you need more from the ENT. What was the question you asked them?
Right.
And what did they say?
Right.
I mean, constant pressure would imply both ears. I mean, I don't know what workup they did. Pardon me. I would follow up with the ENT and say, hey, I need a better answer. Or who do I go to next?
Keep asking questions.
Right.
All right. Dr. Hawkins, some final thoughts?
Yeah, I mean, all good questions. I would like to thank our guests. It's always good to listen to Dr. Barkman, so experienced, and always gives us good information. You know, everybody, obviously we know the virus is circulating out there. Just please take into account those situations that you're going to be getting into. If you're going to be at parties or get-togethers, just understand that you are always free to wear a mask. We know masks do help the wearer. Also, it is greatly important to be up to date with your vaccination. And I don't want this to happen, but it is. We will be getting into further into the summer and then into the fall. We'll be waiting for those further vaccine recommendations, which probably should be coming about in August or early September at the latest. I would think so. When that information comes out, we'll certainly be presenting it to you.
You'll be here.
Yeah.
All right. Dr. Barkman, you got to come back. We have lots of questions coming still from you. So come back and see us, okay?
I will do.
Always. Okay, thanks for being with us today. Don't forget you can catch our updates anytime by logging on to Facebook, YouTube, and Twitter. Tomorrow, at the height of Omicron, it became more and more challenging for staff to find room for patients who died from COVID. A rare inside look at the health system morgue. Ethiopia is thousands of miles from Kansas City, but the health system is playing a big role in the health care of trauma patients there. On the next Open Mics with Dr. Stites, Lights, Camera, Action, the documentary showing the inside story of this unique training program, Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.